We are now going to transition to a roundtable discussion with our speakers, and so I'll invite Dr. Miles to come up. And for those who are online, you can feel free to enter your questions in the Q&A section. And for those in the auditorium, we'll be circulating with microphones if you have a question. So to help us moderate this discussion, we're joined by a wonderful advocate for the allergy community, Ms. Erin Malawer. Erin is a digital health entrepreneur and the executive director of AllergyStrong, a nonprofit aimed at helping at-risk and underserved communities living with food allergies. She's been at the forefront of leading innovation and change in the food allergy community. Erin is an Emmy award-winning writer and producer who's been featured across many major media outlets. She has led key advocacy initiatives at the federal level and guided grassroots efforts across the country. Erin proudly serves on our food allergy task force at Children's National, as well as FAIR's Community Access Program. And we are delighted that she has joined us to help moderate this roundtable discussion. Please join me in welcoming Erin Malawer. All right. And we are going to bring Dr. Gupta back via Zoom. And I believe she's going to be presented. Yep, she will be on the screen behind us. All right, so I'll turn things over to Erin to get our roundtable discussion started.
Make sure this is working. Yep. Hi, guys. How are you? Thanks for having me today. Those were wonderful discussions, all of you. And it's very clear to me that we are all impacted by the environmental aspects that impact atopic dermatitis, food allergies, and asthma. But what is also clear to me is that environmental factors don't affect us all equally. And some groups of people bear a larger brunt of these diseases than others. Dr. Miles, a 2021 study showed that Black communities have less of a genetic predisposition to atopic dermatitis and yet experience it in greater numbers than their white counterparts. What does this suggest to you? What contributes to these kind of discrepancies?
Okay. So I guess it says two things. Number one, that the concept of genetic predisposition is pretty weak in some of this. That study also got spun the other direction and said that, Black communities must have a different set of genetic predispositions to try to explain it. But when you look at rural African communities, their rates can be 0.5%, versus 20-25%. So it really did speak to that kind of environmental injustice angle that they needed to be teased out.
Yeah, and Dr. Sheehan, I mean, does these kind of racial disparities that we have seen in some regards in atopic dermatitis, do these hold true in asthma as well? What about in food allergy? What are your understanding of those?
So there are racial disparities in asthma prevalence. So, we know that in the United States, Blacks have higher rates of asthma as compared to whites. Hispanics actually a little bit lower than whites, but even within Hispanics, for example, Puerto Ricans have much higher rates of asthma, and it's even higher than Blacks, actually. Now, how much of that is due to intrinsic genetics versus how much of that is due to environment is difficult to tease out, and some people are trying to do that. I think recently it's been, I think genetics is a factor, but I think it's become more and more evident that it's probably less of a factor than we had thought all along. And it's probably more environment. And we know the easy way to split it down is if you just take families of high income versus families of low income. Families of low income have much higher rates of asthma compared to families of high income. So irregardless of race. So
yeah, that's an important thing to recognize. And Dr. Gupta, environmental factors aren't the only issues exacerbating these atopic conditions. There are lots of socioeconomic factors that contribute as well, that widen disparities and worsen outcomes. Can you talk about some of those factors that play a role?
Sure, absolutely. And I just want to say, food allergies is very similar. I remember like 20 years ago when I started in this space, it was thought that food allergies don't impact low income and minority groups as much. And we have found that is not true. They do impact all races and ethnicities at relatively equal rates and slightly higher in Black communities. But the whole question about SES is really important in food allergies. As I mentioned, there is a big access issue and for low SES communities. And so they are not diagnosed at the same rates because, again, it's not like asthma or atopic derm. They're not necessarily needing some regular medication for food allergies. It's really, a rescue. If they have an allergic reaction, we give them an epinephrine auto-injector. There are new treatments on the way, which is super exciting. However, not a lot currently available. So we do see a strong disparity in food allergy. And again, similarly, the SES piece, because these low-income families can't get to allergists. And so they're not getting the proper diagnosis and management they need. And in our economic study, we found that low-income kids are spending less on allergist visits, spending less on special foods. So, specific foods that are free from their allergens, and they're spending significantly more, double, triple on emergency department visits. So there are a lot of issues in food allergy that are very similar to atopic derm and asthma, and then also some that are quite different.
Yeah, it's very evident that the environmental factors don't just affect your health; they also affect your financial impacts. They affect your wallet. And management of these conditions can be incredibly costly. Ruchi, I know you sort of hinted at that just now, but you did a study in 2013 that addressed these financial costs in food allergy. What did your study show us?
So we found it's $24.8 billion a year. And a lot of that is out-of-pocket costs for families. A lot of opportunity costs. It's probably similar in the other atopic conditions, but the fear of food allergies and its life-threatening nature causes a lot of parents to change jobs, leave jobs, really be around to manage their child. So that was a big cost. But another big cost was special foods. It is very difficult, and this is a whole nother issue, the whole labeling issue, to get foods with no precautionary allergen label that are absolutely safe for your child, and it's often very expensive. So it is a significant economic burden, about $4,000 per year per child with food allergy.
Yeah, it's really expensive to raise a child with a chronic condition. And as you had mentioned earlier, there is, in these low-income communities, there's less of an expense being paid into prevention and more into emergency management. Does that correlation hold true, Dr. Sheehan, in asthma? Do you see a similar emphasis on prevention versus emergency management? What does that look like in terms of emergency department use?
Yeah, it's difficult. It depends on the city you're in. And Dr. Teach has his famous story where he asked why these families come back to the emergency room so often, and they say, well, that's where the doctors are. Hope I got that right. So part of it is certainly children growing up in urban environments have higher morbidity from their asthma. So they're going to have worse asthma. They're going to have more exacerbations. The exacerbations they have are going to be worse. So they're going to need to go to the emergency room more often. But you're right. There is oftentimes difficulty with prevention, taking care of things that could be done before the emergency room. And Manzi Cotwell, who worked at Children's National and went to Hopkins and now coming back to Children's National, she had an abstract where she showed a lot of these visits to the emergency room were maybe not necessary, could have been treated in a different way. And not to put the blame on any parents, that's where they went. But can we do better things in the community to try to prevent that?
Yeah. So we'll take questions from the audience. I believe there may be a question from Dr. Teach.
I'd like to congratulate the organizers of this session. This has been just outstanding in so many ways. And one of the themes that I've seen running through all the presentations is the role of early life exposure on redirecting development of the immune system away from that, Th2 diathesis towards a more normal, holistic, and probably evolutionarily congruent sort of Th1 direction. So the question I have for this group is, it seems to me a kind of a no-brainer to kind of chase that a little bit, right? And think about how we can maximize very early life exposures to multiple foods and environmental allergens and microbiota, and where should we go? Is there a vaccine that we should be pursuing? Is there an immersion room that we should put all 4 and 6 month olds into a few times a week over certain years? What does the future really hold in this regard? Because I see that as a sort of unifying theme across all the presentations that we heard today.
I'll jump in first. People are going down that avenue, right? So lots of groups are attacking that. At Children's National, as you know, Stephen, we're a site for the Orbex trial. So the Orbex trial is giving killed bacteria to very young children, aged 6 to 12 months, who are, again, at concerning risk for asthma, to try to get them exposed to these bacteria in a safe way, with the thought that can that prevent asthma. And there's a whole company that's working on that, and there's another trial that's coming up using that in older children, and a lot of the people who have done good research, I mean, Sue Lynch is one of them, so she does good research showing that when you have the protective bacteria, that helps. That spun into a whole entire company that's now focusing on how do we get these protective bacteria into young children. And I think it was, Ruchi, was it one of your slides that talked about exposing C-section born babies to the vaginal bacteria, that's a whole nother field of research that's going on. And maybe if it was yours, I'm sorry. It was one of you two had a slide on that, but so a lot of people are working on that. I think we're going to see a lot of that in the next decade. I don't know the easiest way to, take a kid to a farm and drop them off and leave them there for a few years, but how do we replicate that in suburban and urban environments? I don't know.
What I'd like to see is kind of leveraging the insurance company, because like doing the right thing for good reasons, sadly, just doesn't happen. A lot of times it's got to be profitable. And I was intrigued by the school cleanup system. Like, you prevent 2 or 3 kids from a hospitalization. I suspect you've paid for that entire program as it stands. So I think maybe stressing the ability to save money downstream, that somebody will push back and say, oh, it's expensive to go in and do this or that or whatever. But again, if you prevent a handful of kids from going into the ICU, you paid for yourself. From a microbiome standpoint, I am very much nervous about the idea of using them as a therapy, as an endpoint, rather than as a bridge to that environmental strategy, because of what we could see that the same species can behave radically different based on different exposures. The one that always made me uncomfortable from the beginning was the story about TMAO. That was the one where they showed that the reason why red meat would be potentially harmful is that the red meat gets into the gut, and then the normal, healthy, good guy bacteria produce an endothelial toxin when exposed to red meat, and that's because of the heart disease. So on a speciation standpoint, as a probiotic, you'd say, oh, I took my probiotic, it's good. But then if you followed it with red meat, you've now done yourself more harm than benefit. So I know it's tough and it sounds easy to say. It's going to be hard from a societal standpoint, but there just has to be a more genuine understanding. It's what happened with lead. I mean, we got there before the people recognized that lead in gasoline was killing everybody. Let's turn that off. I think we have to do the same thing for some of these exposures.
Yeah, and I'll just a little bit of that. I 100% agree. I think, we talk a lot about prevention of all of this, and Dr. Miles mentioned some of the bacteria on the skin. I mean, there's a lot of work going on, I think an NIH trial looking at protecting the skin. If we protect the skin, can we stop the march? And so that's one route. For food allergy, a lot of what we know is early introduction. So just how do we make it happen? And I love the immersion room. Can we bring kids in and feed them all these foods and send them away with a plan and the foods? I think that has probably been our number one thing, although we are looking at protecting the skin because the skin is the number one risk factor for the food. But, things have changed so much. And how do we change these guidelines that slow down feeding? I think a lot of it came out of fear, 3 to 5 days. Why do we say that? to introduce another food when most of the world just chews up whatever their food is and sticks it in their baby's mouth. So how do we get to kind of an equilibrium? I have to tell a story. I didn't mention that my own daughter has food allergies and atopic derm. But when she was born, it was during the time when they said, do not feed peanuts. And when the LEAP study came out, I was interviewed by the New York Times. And the end of it is, Dr. Gupta slapping herself on the wrist for not introducing peanut to her own child. So there's always guilt, and we're always learning what we know best back then and what changes now. So I second the whole idea of being very careful, at least with the microbiome exposure, and doing it as naturally as possible. And natural ways are, protecting the skin, normal microbiome flora, and early introduction of foods.
It's a good point. And I've been in your shoes too. So we all have to let go of the guilt associated with we're raising children with food allergies, because we're still learning so much. It's a lot of wasted time and energy. I can say that from experience. Atopic dermatitis is considered the first step in the allergic march. And Dr. Gupta, as you just pointed out, it would be so critical to minimize the effects it has on young children. Apart from prevention itself, which we're talking about, we've just sort of discussed, diagnosis is a really important first step. Dr. Miles, can you tell us about some of the challenges there are in diagnosing eczema, particularly in darker skin tones, and what that looks like and what we can do about it?
Yeah, all the metrics are built for, and all the photo books are white skin, big red rash on white skin. And we understand, why it makes it more stark. There's a real big problem that the only metric that the FDA will allow a drug to get approved for eczema is Investigator Global Assessment, IGA. I will diatribe. I'll rant about it in the break if you wish. But it specifically says pink. That's one of the metrics in pink. What we need more than anything, if anybody would like to work on this, would be a picture book in a general publication where anyone can just pull it off of PubMed and get just like, these are the general descriptions of skin of color. There are books that do that for atopic derm and other skin diseases, but you have to purchase it and you'd have to have it around. It would be nice if there could just be a free website or a free journal, open access.
And I know, Dr. Gupta, you've actually one of your slides showed this, and I've heard you talk at other settings about this very issue, and that you're trying to capture some of those images of what eczema may look like. Would you like to comment additionally?
Yeah, I'm 100% on board. I'll join that project with you, and hopefully others in the room will too. We're trying to make a photo book of different skin tones and what eczema looks like. We were focused on infants because of the whole prevention piece. How do pediatricians determine what severe eczema is? Pediatricians had trouble doing that. They didn't understand what we meant by that term, severe eczema. So we created, just from our clinic and taking pictures, a little card that pediatricians could pull up. And if you hover on Epic, it'll pull up that card, which shows what eczema looks like in different skin tones, mild, moderate, and severe. But I love the idea of having a photo book or a publication that people can easily access, because this has been an incredibly significant problem, even for us. So yes, we're trying. I'm happy to share the materials we've developed. We are publishing that. It's under review right now, just that one card, but I think something more extensive would be wonderful.
I can echo that from my own experience. The people that I work with, particularly in the Black community, talk about having to fight for their eczema diagnosis. And of course, the longer they wait, the more exposed they are to environmental and other allergens, which leads them down that atopic march and just exacerbates all of their problems. So I like this collaboration, and I will be following it. Thanks, guys. Again, we're talking about prevention about these diseases in the first place, and you guys have mentioned so many of the strategies that we could use already. I mean, Dr. Sheehan, you talked about the use of biologics. Should we be using them earlier? What are your thoughts on that right now? You may not have answers. You may just simply have more questions, but I'd be curious to hear your thoughts.
Yeah, I think that there's sort of two ways to approach this. So should we be using biologics earlier? So I think the two ways to approach it are, one, should we be using them at a very young age to try to prevent? And I'm happy to talk about that. I think the second is, should we just be using them earlier in the disease process? So nowadays, biologics are more reserved for severe disease, so very severe disease, frequent exacerbations, hospital visits, symptomatology. And it's often kind of the late stages that we then start a child on an asthma biologic. Should we be doing it when they have moderate asthma? Should we be doing it when they have milder asthma? I mean, people often compare it, whether it's good or bad, to rheumatology diseases. So in the olden days, when biologics came out for rheumatology disease, we waited till they were very sick with these diseases, arthritis and stuff, before we started the biologic. Now they start them much earlier and they have much better outcomes. I think there is a push to do that, to start to use it earlier in children who already have asthma, and that's where we can get to the remission and preventing more long-term difficult outcomes, such as declining lung function. Obviously, there's a cost-benefit analysis, and then we also have to think about risks. How much, how much can we use biologics in these young kids, and how long can we use it for, and what side effects should we worry about? These are relatively new medications. So that's kind of using biologic earlier in children who already have asthma. I think there is going to be a push in the next decade to use biologics at a young age to try to see if we can prevent. So dupilumab is now approved for eczema down to age 6 months of age. It will be really interesting to see what happens to the children who have a predilection for wheezing and asthma, and they get dupilumab at a very young age. How is that changing their allergic march that we often talk about? And then the PARC study, it's such a landmark trial because it really is giving these children omalizumab at a very young age to see what happens. So, and I'm not the only one that has these ideas. I'm sure the drug companies do too. So,
yeah, I'm sure you're right. What about prevention measures in atopic dermatitis?
Yeah, there was a couple studies that tried really early Vaseline, basically trying to protect the skin barrier. It looked like it worked. Now it doesn't look like it worked, like it doesn't work. We don't really know. The C-section one with the vaginal flora seems to be potentially relevant in food allergy. That is not borne out in atopic derm either. So yeah, it hasn't been. Of course, now I'm biased. I'm going to say everybody's going to have an air purifier in their baby's room soon enough and burn their sheets and get new mattresses and everything else. But other than that, we don't have a great prevention strategy as it stands.
Yeah, you've convinced me, by the way, to change all my clothing and sheets. So thank you for that. I'll be shopping directly from this conference. Dr. Gupta, what about in food allergy? I know we've talked about some of the feeding guidelines. Are there other things that we should be doing? How well adopted is the feeding guidelines? How are they? How's the LEAP guidance going so far?
Yeah, not that well. We recently did a study among caregivers and found that, it's going okay. Less than half are introducing by age 1, less than 10% by 6 months, which is what would be ideal. We do need to increase this, and awareness and education is happening, but it's never enough. But I think the biologic question is really interesting because we talk a lot now about secondary prevention, and can we? Because now that 50% of the population is introducing early, you're also identifying cases earlier. So many infants we see are developing and knowing they have a peanut allergy, by 6, 7, 8, 9 months. So what can we do with them? And a lot of our European colleagues are actually starting OIT, and a lot of people in the US as well, at this early age. And results are finding that, the earlier you start treatment, potentially these kids, these babies can develop tolerance, true tolerance, not just, desensitization. So it's exciting to think about, how do we use either oral immunotherapy, the patch, they've got, both of those have good data on early age groups and potential secondary, or I don't know if that's tertiary prevention, but being able to help infants early who have been diagnosed, then move on to a treatment that could then lead to them developing tolerance and being able to eat the food freely. And that's being looked at, again, with the same biologics, omalizumab, dupilumab, and some of the newer ones, as well as OIT, oral immunotherapy, and potentially the patch and sublingual immunotherapy. So luckily in food allergy, where there was nothing for so long, there is a lot happening on the treatment side. And can we use this early to then get rid of the disease altogether?
Observations that I had with each of your talks is that each of you are doing research that can have, significant policy implications as it relates to the environment. And I'm curious if you could, wave a magic wand and we could change laws or change policy as it relates to the environment in each of the 3 allergic conditions that you've reviewed. What would you think are the priorities for those policy changes? Dr. Miles?
Yeah, so number one, a full-scale evaluation of air purifiers to accept the fact that like wildfires aren't going anywhere. The same thing that they did with sulfur dioxide, they took a coordinated effort and created the catalytic converter with the law of unintended consequences coming shortly thereafter. But some kind of new filtrate. I'm not talking about getting rid of the catalytic converter because I'd like to not kill everybody with the other stuff that came out. But a new filter that would go into the back of automobiles. And then, kind of what I would love to see more than anything is, how you get the pollen count and it's just a handful of spots throughout a city that will collect the pollens and would register that. There needs to be full gas chromatography at different points throughout the city so that you could get some kind of alert, the way you get for asthma to say this is a bad air quality day, maybe don't go outside. The same kind of things to say, these are bad air quality days for atopic derm.
Dr. Sheehan?
Shilpa Patel is going to talk in a little bit about an intervention program in DC where they're looking at the urban housing and how you can really target that in an effective way. So I think that's a no-brainer, but it's difficult because there's a lot of homes in America. So I think, I throw up the slide in my talk about the schools and pollution. I think that's one way to start. So at least if we can get the schools away from heavily polluted areas, which I understand it makes sense that you build schools in high traffic areas because you want them near where everybody is. But can we do a little bit better job about moving them away from highways, away from major roadways, that kind of stuff, which may be more inconvenient for societies, but I think would be better for children. So.
And then finally, Dr. Gupta.
Yeah, no, this is a great question. I mean, policy for food allergy, I'd say access. Access is the key word, and access to, special diets. So, early access, we did see in our caregiver study that there are differences in education, awareness, and access to a lot of these allergenic foods early in life. We've been working to try to get WIC to include peanut products in their program, which we haven't been successful yet. But how do we get access to these allergenic foods to infants early and to children throughout their lives? A lot of especially during COVID, we found that there was limited access to food in general, and then especially allergenic free foods for people who have all kinds of food conditions. So how do we make that better and change policies to improve upon that? And then the biggest one after that is probably just access to care, and then all these new treatments, the biologics that are coming out, the OIT right now, it's mainly for out-of-pocket. And so, how do we stop the increase in disparities and move towards more equity and access to the foods and the treatments that they need?
Orator, Erin Malawer for joining us today, and each of our 3 speakers, Dr. Miles, Dr. Sheehan, Dr. Gupta, for truly wonderful presentations that were thought-provoking and engaging. So thank you all.